All right, we will get started. Good morning, everyone. Welcome to the March 16th meeting of the subcommittee. We will get right into it. We have a ton of content to share with you all. So a quick overview of the agenda. You'll see it's jam-packed. We have a lot of updates that we want to provide to you all and make sure that you have a chance to ask questions, provide recommendations, etc. As always, just a reminder of our guiding principles for the subcommittee, focusing on safety, minimizing morbidity, efficient distribution of the vaccine, and also access. Specifically, as we moved into phase 2, we refined those guiding principles and wanted to focus on minimizing morbidity and hospitalizations, particularly in vulnerable populations, focusing on equity, and also focusing on reopening the economy. All right, and now I'll turn it over to Tricia Washburn.
Thanks, Mackenzie. Good morning, everyone. Hope everyone is doing well. So this slide here, this is the timeline from when we started in December and provides an estimate for when groups in phase 2 will become eligible. The red line is where we are now in mid-March, where we had started vaccinating teachers last week and opened eligibility to 60 and above and 16 and older with underlying health conditions. This timeline is currently based on current vaccine supply, assumptions of how many people were vaccinated in earlier groups, and an estimated uptake in each group of about 70%. The timeline, of course, is subject to change due to any factors outside of the state's control, such as if we receive less vaccine than what we're forecasting, or suddenly receive more vaccine than what is forecasted. And then also depending on what the uptake is in each group. So we continue to monitor the vaccination numbers in each group, and we'll continue to update this timeline as more information becomes available. So right now, as it stands, again, this can change at any time. But according to this right now, the next age band of 59 and above would be sometime in early to mid-April. Next slide. So this slide illustrates the climb in daily doses administered per week, week over week since early December. As noted here, right now the 7-day rolling average is around 7,600 daily doses administered. The light blue bar are first doses of Pfizer and Moderna. The dark blue bar are second doses of Moderna and Pfizer. And then you'll see the orange bar, which is the single dose Johnson & Johnson vaccine. You'll see there's a yellow line that runs across, and you can see the steady climb in daily average of doses administered. It's important to note that we did the 7-day moving average did decrease slightly in the last 2 weeks, and this is due to administration fluctuation that arises from community, serving specific communities, community-based clinics, as opposed to the state mass-run sites and pharmacy. The throughput is just not the same. But it's still critically important to serve within those communities and have those community-based clinics. But just wanted to note that when you see that slight dip in the past couple of weeks, it's really due to those caveats of not having the mass sites. They have a tremendous amount of throughput at one time. But we anticipate that we'll continue to have a steady rate of daily administrations. The teams on the ground are doing amazing jobs, as I know you all know. Next slide. So here you can see the visual of the vaccinations given according to age group. And you can see highlighted here the large increase in the numbers of people vaccinated between the age of 65 and 74. This is when eligibility opened for that group. And then also right next to that, the following week, the numbers of vaccinations given to people 55 to 64 increased 50% within the last week. And this is due to the opening of the age bands. And so we we're happy that when we are focusing on these specific age groups, that we are seeing high numbers of vaccination in those age groups. So all good signs that we're reaching targeted groups that we intend to. So here is an illustration of the race and ethnicity data. We are still seeing quite high numbers of people vaccinated who are white. We are implementing new strategies to help reach people's communities of color, the high density communities, and Sheena actually will cover more in-depth information about what those strategies are moving forward. And of course, we'd love your feedback. So I will hold on that and allow Sheena to bring that to the group. I'll turn it over to Alicia.
Good morning. So one of the challenges that we've had as we have been looking at our administration rates has been the amount of vaccine that went to the long-term care partnership that was hosted by CDC and utilized CVS and Walgreens to vaccinate individuals in nursing homes, assisted living communities, and other HUD sites with 202 designation, as well as our adult behavioral health group homes. The uptake rate was not as expected, nor were the baseline data that great in terms of how CDC matched staff to numbers of residents at the time that the data was collected at the launch of the program. So we have been working feverishly with CVS and Walgreens, who have been phenomenal partners in this process, to be able to shift vaccine out of its holding pattern and to administer it. So as Trish mentioned on the slide that showed our administration rates, some of the height that you saw was that we pulled vaccine back and administered it as rapidly as possible. We took the rest of that vaccine that was not slated to be used based on continued uptake rates in the second part of the long-term care partnership and used it to support the teacher vaccination, which we will talk about in a few slides. But we've had really great success in terms of getting 100% of our nursing homes and assisted living communities covered. We've had significant uptake rates at those HUD 202 sites, and especially in our behavioral health group homes for staff and residents. And as you can see here, although the second part of the partnership is still ongoing for assisted living communities, HUD 202 sites, and adult behavioral health group homes, we've had a really successful run at second doses for all of those individuals. And so that initiative will run through the end of this month. So we expect to see near 100% completion, if not at 100% completion. CVS and Walgreens are also going to be supporting us as we onboard additional vendors to support the ongoing maintenance of vaccination rates at nursing homes. We have selected 2 vendors who will be, hopefully starting next week, will be administering vaccine on an ongoing basis for second doses for folks who got first doses at the end of the partnership, and the ongoing maintenance of vaccination for any new admissions. So we are very excited for the success of this initiative. As you've likely seen in the data that's been presented at press briefings, it has really significantly reduced our hospitalization rates for individuals who live in nursing homes or in assisted living communities, and we're very excited by the outputs of that data. There are other, I think, really significant initiatives that we undertook in phase 1 that are ongoing. Even though we are in phase 2, we still continue with some specialized vaccination efforts. We worked with the Office of Healthy Aging to run through the 1,300 senior housing sites that exist throughout the state and prioritize them based on social determinants of health and where risk was known to be the highest, just based on a number of demographic factors. So we are continuing to provide vaccination opportunities on site at senior housing, and will continue to do so through this month to make sure that we capture everybody with first and second doses. We also worked with the Rhode Island Department of Behavioral Health Care, Developmental Disabilities and Hospitals and a number of other partners, including Community Partner Network of Rhode Island, to ensure that we could provide vaccination to all adults and adults with intellectual and developmental disabilities who live in group homes, and later on in that initiative, folks who live in the community. We were able to partner with Special Olympics and a number of other community-based organizations to identify other individuals who might need additional support in getting vaccinated and to get those adults vaccinated early. So that is still ongoing. We have 2 remaining first dose clinics, but a significant number of folks who have already received first doses through that set of clinics has also received their second doses. And finally, we are working with a number of home health agencies to ensure that they can provide vaccination to their own clients, but also to clients outside of their current client base. We also we are in the process and will begin next week with 3 new vendors who will be maintaining an ongoing process for vaccinating individuals who are unable to leave their homes in order to get vaccinated, even with assistance. We have over 2,000 people who have registered through the web link that you see there in the bottom right-hand corner, where folks will be able to continue to request assistance for getting vaccinated at home. But we're thrilled to be able to launch this initiative for those who haven't been vaccinated yet.
Before we jump into more, I know we just hit you guys with a ton of data and information. Does anyone from the subcommittee have any questions, comments, recommendations at this time regarding any of the slides we just went through?
Sorry, this is Jonathan Bryce. I'm in my car, so that's why my video's not on. Can I just ask a question? You mentioned about 2,000 people that do not have access, like are unable to leave their home, and we need to provide vaccinations in their home. And you said there was a web link. What about those individuals who may be homebound but do not have access to the internet? How are we supporting them so that they can also get registered? Thank you.
That's an excellent question. Thank you. They can also call our hotline 222-8022 to get some additional assistance with registering through that process. And my apologies for not including that in my spoken words or on the slide.
Yep. And you know what? It might be helpful if we could broadcast that. And if there's like a little flyer or something, I'm certain that school systems would put that out, and other folks would broadcast that, just so that we could help those residents.
Okay, thank you. That's a great recommendation.
Anyone else? Questions, comments about the data we just covered?
Sure. There's a question in the chat box about the resumption of nursing home vaccinations. That's what I was referring to. CVS and Walgreens are going to go back to the nursing homes they covered this week and next week while we onboard our new vendors, so that they will, and then we will have an ongoing process through the end of, the contracts are through the end of the year at this point in time, and we'll continuously reassess, obviously, but that's intended to be an ongoing process with our onboarding vendors, so that nursing homes and assisted living communities will have the ability to contact the vendors to sign up for additional services to come in and vaccinate as they receive new admissions.
And can I ask, this is Joan, is it also true that hospitals will be vaccinating long-term care residents that get admitted but have not yet been vaccinated when they're in that acute stay?
It's a great question, Joan. We think it's a phenomenal opportunity, especially for the Johnson & Johnson vaccine, because it's a single dose vaccine. The challenge that we've had with the hospitals is they've been put in the unfair position of trying to vaccinate and ensure continuity of folks getting their second dose. And because our allocation is so limited, we have not been able to provide consistent supply to the hospitals in order to ensure that everyone who should be vaccinated while they're hospitalized is vaccinated. So they've faced some significant barriers. We've worked with them to vaccinate the highest risk inpatients by categorizations that have exceeded the age bands, for instance, because they are hospitalized. And I have to say they've been really phenomenal partners and have been patient with us as we try to navigate the supply and demand issue. But yet that our goal would be, of course, that would be an opportunity. We see, again, the Johnson & Johnson vaccine as a tremendous opportunity for that, because it means that there wouldn't need to be the arrangement for the second dose.
And Tricia, this is Chris at Neighborhood. Quick question: with that 7-day average at 76.30 in administration, do you have any ballpark numbers right now of the mix of the 3 vaccines that are being distributed to Rhode Island on a weekly basis right now?
So in terms of how many first doses we're getting each week, is that what you're asking?
Yeah, of the 3, Pfizer, Moderna, and Johnson & Johnson, even if you have just the total distribution.
Sure. So and I'll cover a little bit of the allocations coming up, but right now, as it stands right now, our first doses for the Pfizer vaccine each week is around, is it 12 to 14,000? I'm blanking on.
I have it right in front of me, Trish. I can take it. So we currently are getting about 15,000 first doses of Pfizer and about 13,000 second doses, and then 10,800 first doses and 10,800 second doses of Moderna. And then we got an initial bolus of 9,100 Johnson & Johnson vaccines, and then nothing. And then this week we will receive 1,300 doses of Johnson & Johnson, and we don't have a forecast for what our steady state allocation will be. And we're not sure that we'll see that for another few weeks anyway, just to give you a sense.
Thank you very much.
Ultimately, we anticipate that Johnson & Johnson will come in at that, it should at least come in at that 16,000 doses per week initially, and then grow from there.
If you tried to, this is Karen Tashima, if you tried to predict when we would be covering the whole population of Rhode Island, do we look like we're on track for like May, as the president is saying?
So Mackenzie is our master modeler. And so I don't know, Mackenzie, if you want to take it, Dr. Tashima, if you saw the earlier schematic that we have about our projected time bands in terms of where we thought we would be able to open vaccine, you will note that it does not reflect the president's announcement that says where we expect to be by the 1st of May. So this slide is under heavy discussion at this point in time about how we appropriately shift it so that we can allocate vaccine, or open vaccine to everyone by May 1st per the president's recommendation. So we do not anticipate that we would have enough vaccine in order to follow, in order to get to that particular mandate, but surprises happen, and we would love to be pleasantly surprised. Obviously, we've built a ton of capacity into our system in the state-run vaccination sites, and I know we have another slide about some of the expansion that we're currently undergoing to ensure that a lot of our partners have begun the process and are comfortable with the process before we get more vaccine. But I think the answer based on our own modeling is no. We've been talking to a number of other states about what their strategies and their thoughts on this process are. And they've been very open in terms of what's realistic and what's not. I will say, I think one of the challenges, and it's probably one of the best challenges to have, is that we have significant uptake in each of the age bands. And so we've learned over time what the demand signal looks like so that we have a comfortable sense of when we can or should drop the age bands and open to the next group. As you likely saw, we crashed our website on Friday when we opened to folks who are 60 to 64 and those 16 and older who have underlying chronic conditions, because despite all of the build out that we did not expect 500 hits per second on our website. So the demand signal is clearly there, and we suspect that this is the largest of our age bands that we've just opened to. And so again, we'll be gathering the best information we can to make the choices about when we will open earlier to other age groups. But some of our some of our partner states who we've talked to don't have the demands that we do, and so they're ready. We have a couple of states, Alaska open to everybody already. We have a couple of other states we talked to recently who are already have the demand signal where they're ready to open to 45 and older. And we are not in that position because we are still filling appointments as rapidly as we can pump them out.
Great. And it's great that you were able to open to the next age and group bands that last week. That's wonderful.
Perhaps, Trish, we could go a little out of order and I could flip to the allocation slide so that you could explain some of the things that go into how we think about how we inform our projections.
Absolutely. So there were a few pieces of information and assumptions that we utilize in order to predict what we will be receiving and then what the phasing timeline will look like. So for one, we have weekly updates with CDC and they're continually trying to give us some insights into how much vaccine we can anticipate moving forward. Right now, we only have a 3-week view of what vaccine we will receive, which is better than what we had. It was at one point only week to week, and that made it extremely difficult. So right now we do have a 3-week view. And so increases in the supply beyond the 3 weeks are based on historical observations. So at this point, we've been receiving about a 5% increase for Pfizer every 3 weeks. Moderna had started to increase, but then kind of slowed up a little bit. And so for the past 3 weeks, it's been a little stagnant. And then we were told by CDC that we would begin to receive the J&J and could anticipate about a 10% increase every 2 weeks. Unfortunately, with the J&J, we received that one-time bolus of around 9,100, and then the recent allocation, which Alicia mentioned, was only 1,300. However, we're being told that by the end of March, that will be ramped up, and we are anticipating, again, completely an estimate and forecast on our part, receiving about 16,000 doses of J&J per week. So we're hoping that that all comes to fruition. So taking all of that into consideration, and what we just mentioned, Alicia just mentioned in terms of what our allocations are right now, which are around 50,000 first and second doses per week. We anticipate that by June, we would see almost a 100% increase and be up around 100,000 first and second doses each week. So those are all of the pieces that help us forecast what our allocations will look like.
Wendy, I see your hand up.
Hi, this is Wendy Chapoint. I just had a really quick question about allocation. So, there was just a mention about how Rhode Island has a really great response as far as people who want to be vaccinated, and some states aren't having the same response. Is that taken into consideration when vaccines are being allocated to states? Just because, one state may have vaccine, however, they're not utilizing it as quickly. So I'm just curious as to, how that's factored into the decisions around how vaccine allocation is made to each state.
Unfortunately, right now, it's pro rata based on population size. I don't know if the federal government might switch, how they allocate vaccine, but right now it's based on population size. We are working, as you all know, to, the vaccine that we received, to turn it around very quickly and administer within 7 days within our, various channels. It would be great if the federal government modified how they allocate, and we're continuing to advocate for that. The state and the director and the governor continue to advocate for that. So we are pushing hard and pushing back to try to get more vaccine.
Any more questions or comments about the allocation?
Mackenzie, this is Carrie. Clarifying comment here. Is it true that we have halted vaccination in nursing home population as of March 3rd?
No. So the Long-term care partnership has had two significant components. One was for just nursing homes, and the second part was for assisted living communities, HUD 202 sites, and adult behavioral health group homes. We, the third round of each nursing home received 3 clinics. The third round ended March 3rd. That part is true. As I mentioned, CVS and Walgreens are back in those nursing homes this week to ensure that anyone who received a first dose receives the second dose. And then next week, we'll pick up with our contracted vendors to make that an ongoing process. So we didn't want anybody to miss the window of 42 days at most for those folks who were vaccinated, just so that you know that 42-day window goes for the folks who got vaccinated on the first day of the last 3-week period of time. Those folks are due for their doses by March 22nd, which is why we were able to ask CVS and Walgreens to help us out, because our contracting process hasn't moved as quickly as we had hoped. And so we, again, we anticipate that our vendors will all be on board next week to pick that process up, but CVS and Walgreens are helping this week to fill that gap.
Thank you.
We have a question from Dr. Chowdhury in the chat, so I'm gonna flip back to this slide, which I think is what she's referring to. So Dr. Chowdhury said there seems to be a big gap between allocated vaccine and administered doses per week. Could you explain what might be causing that? So I'll start by saying that the 7,630 is a daily number, and the allocation numbers that Trisha mentioned a moment ago were weekly numbers. So the 15,000 Pfizer first doses and the 10,800 Moderna first doses, that's how much we get per week. And then this is our 7-day rolling average of total doses, which would include first and second doses. Dr. Chowdhury, does that help? Or did you have another question based on this slide here? I know there's a ton of information here. Well, if you do, put it in the chat and we can circle back to it, no problem. Okay, so I'm gonna move us along to the next, back onto the agenda to the next slide, although that was really great that we were able to talk through our allocation process. It's very complicated. All right, so I will turn it over to Sheena Gordon to talk through some of the continued efforts to expand in high density communities.
Thank you, Mackenzie. Good morning, subcommittee. Wanted to give you all an update on where we are with the HDC high density community strategy and what some of our key priorities are for the month of March 2021. Last week, one of the big announcements was being able to expand the HDC effort to all of the tier 1 zip codes. So in Providence, that added 02904 and 02905 to the zip codes that they were targeting. The other great thing that we were able to do last week was connect with both CVS and Walgreens and identify ways that they could help us target the high density communities using resources that they already have access to through vaccine, through their federal allocations, being able to go into the community and do community-based vaccination clinics, as well as reserve slots at the pharmacies for residents of the HDC zip codes. This week, we've been working a lot on sort of how do we track and measure the performance of the HDC strategy. So looking at, equity metrics, how we're doing versus vaccinations, and how the vaccination rate in the HDC communities compares with the rest of the state, and really trying to find ways to focus on the HDC communities so that there's better vaccination rates that are happening there. We're continuing the clinic onboarding, both for medical providers and community-based organizations. So one of the things that we really tried to do in the HDC channel is to stay ahead of the supply. So building the capacity within the network to take as much vaccine as possible, up to about 14,000 doses a week. Right now, we have a capacity that could get us probably about 9,000 doses. So we're pretty close. One of the things that we are excited about is the ability to have HDC residents have reserved days at some of the Rido vaccination clinics. So we're starting with the Socket Pod and the Dunkin' Donut Center. And our hope is that once Woonsocket comes online, that will be another source of HDC vaccine reservations, not only for tier 1, but hopefully as we move into April, we can also use those sites for tier 2 as well. The other thing the other big opportunity that we've had is that the Wellness Company will be able to do more of the community-based clinics, which will allow us to engage a lot of our community partners that we, partner with the HES and other organizations, the health equity zones and other organizations to identify, to be able to do place-based vaccinations. And so whenever we're doing those, we can go into whether it's a housing authority or a church or food pantry. Our goal is to go in and be able to do everyone who's receiving services there. So it would be 18 plus for Moderna and J&J, and then 16 plus for Pfizer. So in those place-based vaccinations, we'd be able to kind of accelerate sort of on a one-off basis, the ability to get to people who are a little bit below the current, well, significantly below in some of these cases, below the current city floor for the age. The other thing we've been able to do is open or encourage not only medical providers in the HDCs, but also our hospitals, other CHCs, and other medical providers that may be vaccinating to prioritize their residents who are 18 or 16 plus, who come from HDCs but have underlying conditions. We know that there also may be a fair number of people who have underlying conditions in the HDCs who may not be accessing medical care. So that's why we still feel like the community strategy and the clinic strategy within the HDCs is going to be important to make sure that these people are addressed. And as we kind of think moving forward into April, hopefully the weather gets nicer and there'll be more opportunities for sort of outdoor pop-up clinics using some of our mobile vaccination resources. We're working right now actually with the City of Providence, PCHC, the City Council there, and the One Neighborhood Builders to have an event for the Smith Hill area where they would be doing vaccinations at the same time as an Easter, I think it's an Easter egg roll or something of that nature. And they've also expressed a willingness to stay there for 4 weeks. So that would be another place where we'd be able to do kind of an outdoor pop-up event to vaccinate people who are in a community that may not otherwise, be going to some of the other locations to get vaccinated. So we'll continue to expand the capacity and the number of vaccination opportunities, not only through the HDC channel, but also through the other channels in our operations, and look for opportunities to move quickly down the age bands. I think other than Central Falls, both Providence and Pawtucket are both at 50 plus right now, but are looking at opportunities to lower that, as well as for people who are 18 or 16 plus with underlying health conditions. Happy to take any questions on that.
Hi, this is Pablo Rodriguez. I have a question. I have a couple of questions. First, the reservations for the high density communities, is that going to be through Prep Mod or through another tool? The second question I have is about, I was at a meeting with the governor and with the mayor of Woonsocket, and she was reporting that Latinos in Woonsocket were being hesitant about the vaccine, and they were not seeing significant numbers of people getting vaccinated. So I was wondering about that as well, and whether there's another push for marketing to the Latino community, who obviously the numbers are not reflecting their numbers in the community and their impact by the virus.
Thank you, Dr. Rodriguez. To take with your first question, there will be Prep Mod links. So the municipal teams in both Providence, Pawtucket, and Central Falls, so sorry, not both, all Providence, Pawtucket, and Central Falls have been provided with access to those links. They are Prep Mod links, but they're reserved, they're not public, so they're private. And 311 and Beat COVID as early as this morning will start to register people for the Rido vaccination site clinic. So it will be through Prep Mod, but it won't be public in the way that you would be able to see it on Vaccinate RI. Folks will have to call into the websites, call into those municipal sites to get access to those appointments. And there they will check to make sure you're a resident of the proper zip code. You may meet all the eligibility requirements before proceeding with signing you up for one of those days.
So just to be clear, that then people in the high density communities will not be able to go directly to Prevmont to do this. They have to call the municipality in order to access.
Sorry, the municipalities will also post it on their websites. So you could go to like Vaccinate for Providence, Vaccinate PVD. I can't offhand remember the one for Pawtucket, but you'd be able to go in there to register as well. Right. We found that a lot of people are calling in, just, given, I think, one, the realities of the age band, but also just access issues and trying to get onto the sites quickly. The call lines are getting a lot of traffic. So I probably led with that, just anecdotally hearing that a lot of people are calling in, but those links will also be available on the local vaccination websites. They will continue to scrub those clinics even after people register to make sure that folks who are ineligible are removed from the clinic. Right. So that we can really prioritize the HDC residents.
Great.
And then the second question about, Dr. Alexander Scott, were you gonna jump in?
I was gonna jump into support, but you got it. Keep on going.
On the second question, I think, I agree with you. I think there's always the opportunity for outreach and education around the vaccines, particularly with sort of new products coming into the marketplace. And I think that's one of the things I thought I saw Sophie on, but we've been working with communications on around canvassing and things of that nature. I do, we'll have to kind of talk through with communications the opportunities to really ramp that up, particularly in the tier 2 HDC zip codes, because there has been a lot of focus on the tier 1 zip codes as we really, not only around vaccine, but also around masking and testing and treatment. And so, we'll continue that work around communication and education, to combat hesitancy where we can, but we know that there's also an access issue. And so being able to put the access there and sort of see how people are responding to that, I think is going to be really important. When I think back to the early days of Central Falls, we thought that no one was going to take the vaccine. And once it was there, we were able to fill the clinic. So I think it'll be interesting to reevaluate sort of how things are happening once the access of it is available. But to your point around hesitancy and education, there's always an opportunity for that. And we do need to continue the efforts around canvassing, providing community members with with information, the education they need to make informed decisions.
That's perfect. And before jumping in to share more on the communication strategy, as Mackenzie appropriately skipped forward to, we welcome this. Well, first of all, good morning, everyone. I've been enjoying our interaction and engagement. The team did a great job pulling everything together. We welcome this subcommittee also helping to push the message of access being a key starting point for our communities of color. There's certainly the recognition of the hesitancy, but we don't want it to be pinned just on hesitancy when we know from an access standpoint, we have an allocation ramp up that we are focusing on for our Pawtucket and Providence zip codes in tier 1 to get to a level that is equivalent to the allocation we had for Central Falls. And with the credit to the team, there's a several weeks process for getting our allocation amount ramped up to that level appropriately. Really pushing on the access piece is a critical component to ensuring that our communities have the ability to participate in our vaccination campaign. And so our tier 1 focus is 18 plus, and particularly due to the encouragement from Dr. Chowdhury during our last call, we are also expanding in tier 2 to all of those with underlying illnesses among our clinical providers in hospitals and other settings. So that's an important outreach focus that we will continue, and also be able to push on the communication side. So with that, I'll turn it over to our comms leadership to walk through this.
Sure. Thank you, Dr. Alexander Scott. Good morning, everyone. Like Sheena and Dr. Alexander Scott mentioned, when it comes to our communication strategy, we're really focused on both helping people understand how to access vaccine and then also on building vaccine confidence. And so we are currently in the process of updating our overall strategy, moving into this next phase of the campaign. So that includes thinking through specifically how do we focus our efforts in communicating well in our high density communities and addressing barriers to vaccination that we know exist there, as well as more generally when it comes to the statewide population, working to increase vaccine confidence generally as well. From the start of our vaccination campaign, we've been really focused on basing our communication strategy in formative research with Rhode Islanders, including Rhode Islanders living in high density communities. So we conducted a lot of research in the beginning of the campaign, but we know that a lot has changed since then, especially as more Rhode Islanders have become vaccinated. We really want to see what has changed when it comes to hesitancy and general vaccine confidence. So we are conducting additional research now to understand where we are currently and how to focus our strategy most effectively. I won't read everything on this slide, but just a few components of our strategy include a lot of community engagement with a lot of different groups, including this group. We always welcome feedback on how we could be doing a better job communicating with our communities. And so we've really welcomed the ongoing engagement and interest that folks have taken in this issue. We are doing a lot of outreach and presentations to various groups to help answer questions that they have and discuss vaccine safety and the vaccine development and approval process. We're implementing some more grassroots strategies such as canvassing, direct mail, because we know not everyone is getting their information on social media or through the website. So we're really trying to have a multi-channel approach that includes, printed pieces and in-person interaction as well. We are updating our paid media campaign. So we're in the process of developing new creative, including creative pieces specifically tailored to our high density communities. And we're oversaturating our entire paid media campaign in our hardest hit zip codes. And we're continually looking at the data and making changes in the media plan to make sure we're targeting our media dollars most effectively. And then we've got a lot of resources that we're happy to share with people. I think we have another slide in the appendix of this deck with a lot of different resources. We've developed community toolkits. We've got a lot of translated information. There's some great materials coming out nationally as well that we've been working to share with folks. So if anyone doesn't have this, we're welcome to share it with you. And again, to take feedback on what else we could be producing that would be helpful.
Thanks, Sophie. I'll go ahead and I'll put the resources in the meeting minutes so that anyone who wants to access those can have those at your disposal. Any questions about the high density community strategy or the communication strategy? Or comments?
This is Joan. So is there a sort of caseworkers literally like walking around and talking to people? Because I know in Newport that's one of their communication strategies is to, really literally boots on the ground and just walk around and try to find folks and share this sort of information. Is that a part of your strategy as well? I may have missed that, I apologize.
Yeah, so we have a canvassing strategy that's specifically working in our high density communities. So we've got folks going out into communities, delivering literature to literally every door in the community and interacting with residents in the process. So that's definitely part of our strategy. There's also a lot of really great work that our health equity zones and our other community partners and the cities are engaging in to do more of that one-on-one conversation and direct outreach in person with residents. And so we're doing some stuff on the state side, but we're also, there's been great work happening locally as well. And so we're working to support and coordinate and collaborate on those efforts as well.
Great. Well, I'm going to move us along so we hopefully can have time to read out some of these public comments, although we've read a few already. Okay, so I'm going to turn it over to Alicia to talk about our effort to vaccinate educators.
Thank you. So as many of you saw last week, the Biden administration announced the intention to get a first dose of vaccine in the arms of any teacher, member of the school staff in pre-K through 12 environments, and childcare workers who would like to be vaccinated. And so, as I mentioned earlier, we were looking at our vaccine allocations and really scratching our heads trying to understand how we could find enough vaccine to make that happen. And because we had already been engaged in conversations with CVS and Walgreens about the ongoing efforts for vaccination, we were able to borrow from that pot of vaccine and bring that vaccine into the state sooner so that we could embark on this initiative. We found also that because CVS was receiving federal allocation, that they received the mandate to open their appointments to teachers as well. The teachers were very organized and immediately got on getting appointments through CVS and eventually Walgreens as well. So we developed a strategy with our municipal partners who have been very interested in supporting individuals who live and work inside their municipalities specifically. So they were excited about this opportunity to be able to vaccinate, again, folks inside their own communities, and were able to rapidly activate their points of dispensing or pods and get links set up for the timeframes in which they would be vaccinating. And we have been funneling the vaccine to them in order to support this initiative. So the last week we began Thursday of last week with 2 municipalities and then had a tremendous number of municipalities vaccinate over the weekend. So those close to 5,500 administrations happened just over the course of those 4 days last weekend. And we have another very busy weekend planned for first doses this upcoming weekend. Some of the larger municipalities will be vaccinating over the course of 1 more week, just because they were trying to appropriately right size their pods so that they were able to vaccinate. But we do know that through the other channels, folks were able to make over 13,000 appointments to get vaccinated in other locations. So our demand signal here is slightly lower than we originally anticipated, but will still be significant in terms of ensuring that anyone in this group who wants the vaccine will have access to it. So we've been very excited by the outpouring of enthusiasm from this community to ensure that they get vaccinated, in supporting the president's and the governor's strong push to ensure that teachers, school staff, and childcare workers are vaccinated in order to support some of the ongoing initiatives in terms of being able to maintain a steady state of staffing in those environments so that kids can return to school, which supports the return of the economy.
Any questions, comments, recommendations regarding our the data that Alicia just presented?
The other piece I will encourage is the early child care staff component. There's definitely an understanding and a mechanism for outreach to our pre-K through 12 communities, but outside of the licensed entities for childcare and early childcare, it's a little bit more challenging, particularly in our communities hardest hit or communities of color. So for ways to access them or get that word out, it's something that we welcome support from this committee to help ensure that we are reaching all of those who are involved in full-time childcare and early childcare education.
Great. Well, I'm going to move us along. We're almost through the agenda. We already talked about the forecast. So our last topic is just to give you guys a quick update on what we're doing regarding inventory management and vaccine distribution. So I'll turn that over to Alicia.
Thanks, Mackenzie. So this has been a wild learning process for all of us as we continue to try to refine our processes, work with our partners, and build better efficiencies into the system so that we can ensure that as rapidly as we receive vaccine, it is distributed and administered. So we have been enhancing both our inventory tracking and reporting by our partners to ensure that, again, we have access to the data and that we can really drive down the amount of time it takes from the moment the vaccine arrives in the state to the time that it gets into arms effectively. So we now have more detailed inventory tracking across all of those partners that allow us to have better insight, not only into what inventory they have on hand at the start of the week, but also what their planned activities are so that we can then check in midweek to make sure that they haven't had any barriers to administering the vaccine on the schedule they had originally intended. And if we have a partner, for instance, who was unable to execute a clinic or had lower uptake or lower interest than was originally anticipated, we're able to then quickly shuffle vaccine either within one of the main channels or across channels as necessary. As you may recall, we used to have a slide that showed an original timeline that showed that it was about 8 to 14 days after the receipt of vaccine that we were actually administering, because we didn't have a level of confidence initially with the continued and stable receipt of vaccine. And so because our partners have been performing very well, despite even the worst weather that we've experienced in the southern part of the country, we now know and understand what that cadence is, and we've been able to rapidly drop that time frame from 0 to 7 days in some cases, so that we are able to minimize any inventory that anybody perceives as potentially sitting. We are able to, again, just reallocate vaccine as rapidly as we need to. We have a standard now with our partners that the key is to administer at least 90% of their vaccine over the course of the week. And if they aren't going to use it, then they need to contact us with either a remediation plan or for the return of vaccine so that we are able to quickly reallocate it. And this allows us to, again, make those changes as rapidly as we possibly can to ensure that because we have such high demand for vaccine and we have a lot of available capacity, that we're able to funnel vaccine to the places where it can be administered as quickly as possible.
This is our last slide before we move on to public comment. Any other comments, questions, recommendations on any of the material we presented today from the subcommittee?
Good morning, this is Chris Abalime. Good morning, everybody, and thank you for the presentation. I just have a quick question out of curiosity. As far as the educators is concerned, do we have a sense on when that will be complete? Like at what point do we say, yeah, we have sort of completed that population and move on to another? Do we have a timeline?
Alicia, I don't know if you want to take that one, but the goal is March 31st to have all educators who want to be vaccinated. Anything else, Alicia, to add about that process?
No, we anticipate at the end of the month, if there are individuals who either were unable to get vaccinated for some reason, we have, childcare workers we've heard about who are in quarantine and have, significant concern about missing their opportunity to get vaccinated. We will open all channels to all educators at the end of the month to ensure that folks have an ongoing opportunity to be vaccinated.
Thank you.
And I think, Alicia, the municipal support and the community clinics are planned for 1 to 2 more weeks. Is that correct?
That is correct. They run through next weekend, the 28th. So again, it's just been a phenomenal opportunity for folks to engage with the communities. Obviously, the smaller communities who were able to vaccinate very rapidly because it was a small number of teachers within their community may have held only one first dose clinic. And so again, if folks miss that opportunity, they're welcome to go to CVS or Walgreens. And as we continue to expand through the pharmacy partnership, those the other pharmacies that are coming on board will be able to vaccinate teachers as well, or they'll be eligible to go to mass vaccination sites.
I'm going to go ahead and jump to some of the public comments so we have time to read some of those out. We've answered a few of them already regarding homebound individuals and the nursing home, the maintenance of the nursing home facilities, vaccination efforts. So I'm going to scroll past those. We have a comment here regarding, here we go. That's a quote from an article regarding DCYF caseworkers and their ability to be vaccinated. And just a request for us to reference this Boston Globe article regarding concerns around the social workers that have not been yet vaccinated through the BH-DDH partnerships, who are client-facing and who are at times in people's homes and other times who haven't been able to see their clients due to the pandemic. So I'm not going to read the whole article quote, but we'll post that there in the minutes if you want to reference that article. Then we answered Dr. Chowdhury's question about the gap between allocated versus administered. Regarding DCYF workers, they're not second responders, they're first responders. The police and hospitals contact DCYF for emergency response to child abuse and neglect.
So we worked with DCYF, DHS, and BHDDH on the highest risk workers, and there was initially a tiering process through the Department of Administration's HR. And so those folks who were in priorities 1 and 2, as designated by the leadership of those agencies, were offered the opportunity to vaccinate. It was our intention to continue to move through those prioritization groups, but because the data showed that the age band strategy would be more effective at reducing hospitalizations and deaths, we shifted all state employees back into the age band strategy. This is a common concern that we've heard about essential workers across state government in terms of folks who may also be public facing and have interactions. But it was, again, in conversations with the leadership of those departments that those prioritizations occurred.
Thanks, Alicia. Another comment from Dr. Chowdhury, there's a higher uptake in hesitant communities like Woonsocket when the vaccine is administered at their PCP's office or their local clinic. Absolutely, and I think at least starting in the HTC communities, we're really trying to bring the vaccine as close to where folks receive services already. So we have some questions about nursing home facilities and why the staff cannot administer the vaccine. And then whether or not we are prioritizing people who are going to be discharged into the community.
So I answered that one further down in the chat, Mackenzie.
Mm-hmm.
The second part I did not see. I apologize, Deb. The homebound vaccinations will begin likely next week. And we did meet with the Office of Healthy Aging again this week. So the vendors who are onboarded are all mandatory reporters and have all our medical providers. So they have already been trained, but we do have the trainings and the one-pagers from OHA that we'll be sharing when we onboard them later this week to ensure that if they see signs of abuse or self-neglect, that those get reported as well.
We have a great recommendation to make sure that the various phone numbers that we've spoken to today are listed on all printed materials so that people who do not or cannot use technology have access. So Sophie from Wendlicken from Communications just spotted that that's a great idea, and we'll make sure to work to get those phone number is more public facing. We have a comment that some Brown students have put together an informative Instagram account and have students who will volunteer at clinics to promote vaccination, and reach out to them if we'd like them to assist, and that they've already been working at the Johnson vaccination site. That's really awesome to hear. I'm going to personally check out their Instagram at Brown Boost Immunity. Let's see. Another request to remind people to cancel appointments or make it easier for them to do so, as there appears to be no-shows. And this individual, Heidi Ross, witnessed this yesterday at CVS. And so we're continuing to message that, and it's a great recommendation. Oh, this is great. The communications team has an after your vaccination handout that will include this info and be making it available, but want to continue to share these messages widely through all the channels that Sophie listed before on the communication slide. I'm hearing staff at Boys and Girls Club are not eligible to be vaccinated because the club has not gotten state approval as a licensed childcare site. What can be done to help get the staff the vaccine? Alicia, would you be able to speak to how we categorize our pre-K childcare and early childcare staff designations?
Sure. So we did use the licensing database for Department of Human Services Child Care Services, and that was our primary source of data. So we can revisit that to see if there is enough, if there is a recommendation for Boys and Girls Club with our prioritization committee.
Great. Can targeted vaccination efforts continue for 75 and older cohort to minimize deaths? Yes, absolutely. Dr. Alexander Scott, do you want to add anything there?
No, that's actually a good way to end. We definitely want to make sure that we are continuing the focus for vaccines, particularly once supply kicks in, given the promise and intent from the feds. Many of the relationships and community coordinated activities that we have set up for vaccinating targeted groups, particularly from that equity standpoint, such as our seniors, our homebound communities of color, are approaches that we will want to continue for the long term to help ensure that we get as many individuals who are willing to get vaccinated. So we'll welcome your support on helping to ensure over the next several months that we are reaching every single individual in Rhode Island that we can.
Thank you. And I will end by just giving an update on the meeting cadence going forward. So the subcommittee will now be meeting every other Tuesday. So the next subcommittee meeting will be on March 30th, unless something arises in the meantime that warrants attention sooner. So we will see everybody on March 30th. Thank you so much.